It's my pleasure to introduce Dr. Adami. Dr. Adami is a professor and Alexandra Yao Chair in the hematology, the director, Division of Hematology at University of Toronto, Section Head, Division of Hematology, Oncology, and the Center for Global Child Health. Currently, I want to say that Dr. Adami is the medical director of the Global Sickle Cell Disease Network based out of the Hospital for Sick Children that is committed to building enduring collaborations between clinicians and scientists worldwide to further sickle cell research and advance clinical care for patients, particularly in low middle income countries that shoulder the heaviest burden of the disease for children. So please welcome Dr. Adami.
Thank you. Thank you very much. I'm very grateful to the organizers of this conference for giving me the opportunity to participate in this conference. I think I last attended a conference several years ago, and sitting there and learning from what is presented here, I have to say that the Sickle Cell Association of Alberta has made significant progress, and you should be very proud of yourselves. So when I was asked to participate, the organizer kindly asked me to choose the topic. And when that happens, actually it's a double-edged sword, because you don't know what others are talking about, and you don't know whether you're going to fit into what they're talking about. But I knew that transplantation and cure was going to be a major theme, a major focus of this conference. And we have seen that, even seeing 2 patients who have been cured through transplantation. So that is great. So what I wanted to cover is, and this is the message, I think sickle cell disease has never been in a better place today. As we speak, the NIH invests $100 million every year in sickle cell research. The American Society of Hematology has made sickle cell disease research, clinical care, advocacy, a major focus for what they do. Apart from that, there are new molecules and new drugs that are being studied that are undergoing clinical trials. The last count that I had, about 10 or 12 different molecules that are undergoing clinical trials to come into treatment for sickle cell disease. We have waited so long for this, and we are now here. And not only that, all the big pharmaceutical companies that we know are now entering the sickle cell space. So we have not been in a better place, and I think what we are doing here is going to help us achieve the ultimate goal. So my objective is to let us gain some understanding into efficacious treatment for sickle cell disease and recognize some of the key barriers in implementing these efficacious treatments. And the reason why I want us to do this is, if we learn from the treatment that we already have, the barriers to access, the barriers to using them effectively, when the multiple other options come, we will know how to use them effectively to improve patient outcomes. Because making a discovery or having evidence does not necessarily translate into practice. Alberta, only this year, approved universal newborn screening for sickle cell disease after so many decades of evidence. And so what I wanted to discuss is strategies to bridge that gap and to know how the systems need to change to advantage. We've seen this already, so I won't really go over what sickle cell disease is. So people ask all the time, we don't see a lot of research in sickle cell disease. But actually, there has been some amount of research that has generated strong evidence. So the evidence that really made newborn screening for sickle cell disease mandatory was this penicillin prophylaxis study, which was published in 1986. Had it not been for this study, we wouldn't know that giving children penicillin in early life is going to prevent mortality. And so when I see my families in Toronto and they are not taking their penicillin, I explain to them, were it not for the evidence that penicillin is useful, we wouldn't need to do newborn screening. The child will be diagnosed anyway at the age of 2, and we heard the stories, age of 3, age of 4, they will be diagnosed. But why do you have to detect them at birth and not much later on? It's because penicillin is of benefit. And this prophylaxis trial actually gave the mandate to do newborn screening across the United States and then spread throughout the rest of Europe, and now I'm happy to say Canada. The hydroxyurea clinical trial was actually published in 1995. And this is a double-blind placebo trial, a gold standard of clinical trials. So you mentioned hydroxyurea, and people say, is it a new drug? Is it new? I've never heard about it before. Hydroxyurea itself was discovered in 1892. It's as old as centuries. Its use in sickle cell disease actually became evident in 1995. And yet, too many sickle cell patients in Canada today who should be on hydroxyurea are not. And the question is, if another treatment comes, are we going to face the same barriers? Even if cure comes, are we going to see the same barriers in accessing what works for patients? There was a trial on preoperative blood transfusion. We learned that. Even what to do in pregnancy, whether pregnant women need transfusion prophylactically or to wait when they need it. This study showed that there wasn't real difference in doing prophylactic transfusion than giving it when they need it. We also had a stroke study, which to me has been one of the most transformational studies in managing children with sickle cell, that we've been able to reduce stroke by over 95%, which is a major success story. I was saying in the clinic only last week that I don't remember the last time I saw stroke in a child because all of them have graduated and become adults, and only a few of them, and the few that have had stroke that we are seeing in Toronto have migrated from other parts of the world. And this is amazing to see, because before then, 10% of patients with SS, by the time they are 14 years old, will have a stroke. And you can see how devastating a 3-year-old having stroke would be for the educational achievement, for care, and for families who are trying to help them navigate. So that's a success story. The STOP-2 trial suggested that you don't stop transfusions in these patients, and that if you stop transfusion, they'll continue to have stroke, and that you need to continue the transfusions. The hydroxyurea in the very young, people say, is it safe in a child? Are you going to give hydroxyurea to an infant? The evidence for that came in this trial, which was published in 2011, that the hydroxyurea is safe in children, and in fact, children tolerate hydroxyurea far better. I find that adults have more difficulty tolerating hydroxyurea. Children tolerate it much better. We talk about using hydroxyurea in the prevention of stroke. Whilst we know that it's not as good at transfusions, there are many patients who are using hydroxyurea to prevent a second stroke. And this is based on the SWITCH trial. Then we have the silent infarct trial, which was an eye-opener. We now know that if you don't do an MRI in a child or an adult, you wouldn't know that they have a silent infarct. And I think standard practice for a patient with SS or S-beta-0 thal is that they should have routine MRI of the brain, because if you look at the brain as an organ, you need to look at how the brain functions to be able to provide care for them. So there are various strategies for managing sickle cell. I haven't included everyone, but each one has a role. The preventive strategies and newborn screening is one of them, and I'm happy that Alberta is joining the fray. I think we should campaign that no province in Canada should be without newborn screening for sickle cell disease. Immunizations are very important. Stroke prevention is critical. And then early recognition of end organ damage. So let me make a point here. The notion that a sickle cell patient is okay is completely wrong. You don't have to measure health by crisis. And we have been made to accept this model that unless you are hospitalized for a major crisis, that somehow you are well. We've heard from the patients themselves. They're struggling with this at home. They are struggling with this at work. They are struggling with this in school. They are not perfectly healthy, but we may think they are healthy because relatively they are not suffering crisis. I think the management of sickle cell disease should shift from crisis management to protecting end organs. Because ultimately, what shortens lifespan is end organ damage. And if we really want to give them optimal health, then our focus should be on end organ. So for example, I had a mother in my clinic. I said, your daughter will benefit from hydroxyurea. She said, well, my daughter is perfectly well. This was a 10-year-old girl. So I said, okay, we're going to have a brain MRI. And there were multiple silent infarcts. And as I showed the MRI to the mother, I said, this girl you said is perfectly healthy. You see those white spots? You see those white spots? Those are silent strokes in the brain. And her eyes opened because she now realized that what seemed to be a healthy bouncing girl is having some organ damage. Sickle cell disease is a chronic inflammatory disease that needs to be controlled continually to protect end organs. And that's the way we need to look at this disease. Pain episodes, we've heard about that. We've heard about acute chest syndrome is a great cause of mortality, and multiple organ failure, which often is what is a terminal event for adults. Strategies for modifying disease is therefore the way we ought to go. Hydroxyurea therapy, those who are chronic transfusions, and Dr. Ritchie has been a great pioneer in using exchange blood transfusions as a way of treatment. And I think that's a great disease-modifying therapy because it prevents the iron overload that usually comes with multiple blood transfusions. And we've talked about transplant, and thankfully, gene therapy and gene editing is coming. And this is really, truly here because clinical trials are happening. We've seen this graph, but this is what I wanted to, in the United States, it's been a long, long struggle since sickle cell disease was published in the literature. You can see almost a flat curve. And then the National Sickle Cell Act was passed, and that allowed a lot of the research that I'm talking about, penicillin, hydroxyurea, blood transfusion, stroke prevention, and that has made a significant difference. Where we are now is actually to let this continue to improve survival of patients because we know that we have a better understanding of sickle cell disease. So I'm going to use hydroxyurea, not because I'm pushing hydroxyurea, but I think that even if you are waiting for a cure, and hear me well if you're a sickle cell patient, even if you're waiting for a cure in the next 5-10 years, please let's preserve your organs, okay? Because a damaged organ will not be reversed. So the notion that, oh, I'm waiting for something better, please, while you're waiting, we're all longing for more than hydroxyurea, and we are almost there. We're going to have better sort of options for you, so you can choose which one is favorable. But while we're waiting, your organs need to be preserved. And I can't think of any simple drug that you take by mouth once a day that does so much for sickle cell. And this is just showing you the difference that a patient before hydroxyurea and after taking hydroxyurea, there's a blood smear shows. This is a slide from Dr. Aware, who has done a lot of research in this area. And you can see the reduced sickle cells. You can see that the cells have more hemoglobin in them, and the number of sickle cells are reduced, and you can tell that the hemoglobin is higher. And this drug has been researched a lot. All this is showing various research that has been done with hydroxyurea. We don't need any more research to prove that it works. What we need to do is to implement it. Make sure that every patient has access to this drug, whether they can afford it or not. And we give them the confidence to take this medication. A lot has been done on this drug, and I think that should give you confidence that this drug has been studied a lot. So this is just putting together the baby heart trial that look at toddlers and young children, and the adult study. And you can see the benefits. So this is placebo, those who took placebo, and those who took hydroxyurea. You can see in pain, there was an improvement. In acute chest syndrome, there was improvement comparing hydroxyurea and placebo in both the adults and the infants and toddlers. Hospitalization rates were reduced, as is need for blood transfusion. This is gold standard no more study. And so I believe that it is unethical now to conduct a clinical trial anywhere in the world where you're giving some patients hydroxyurea and the other patients placebo. It's unethical. Some people have tried doing it in Africa and have stopped them doing it because the evidence is so strong. Giving placebo to any patient with sickle cell comparing with hydroxyurea is unethical because it's been proven beyond doubt. And not only does it improve these symptoms, we now have data to show that it's improving survival. So this data from Greece, and we heard yesterday that yes, people in Greece and southern Italy have sickle cell. It's not only a black disease. This is a patient in Greece. And in this hospital, this one institution, the patients who were worse, who had many more crises, were put on hydroxyurea. Those who were considered to be relatively milder were not. And over time, they could see that those who were on hydroxyurea actually were doing far better than those who were not. So it's associated with survival if you can persist in taking the medication. And what about harmful effects? Because that's the first question everyone will ask. You mean I'm going to take hydroxyurea for the rest of my life? What are the harms? And this has been studied a lot, that it does produce bone marrow suppression. And that is how it works. It needs to suppress your bone marrow to be able to stimulate fetal hemoglobin response. Some people have said it worsens their leg ulcers, and that is true. I've seen that in some patients. Leg ulcers are not very common in our group of patients, but in the tropical part of the world, leg ulcers with sickle cell is far more common. And the fact that it causes leukemia, because that's the danger that people always fear because it has anti-leukemic effect, is very low evidence. And this drug has been used in other patients with what we call myeloproliferative disorders, disorders of the bone marrow where the bone marrow is too active, and this drug has been used for decades. Now, reproductive effects, I will agree that hydroxyurea can reduce sperm count, and that has been documented. It can reduce the sperm count, but there's no real evidence that it causes infertility. And in fact, I don't know, Aisha, in my clinic, my primary aim is to prevent unwanted pregnancy. Because if you don't, it happens. We spend a lot of time to make sure that people have children when they really are ready for them and when they really are better equipped to care for them. So let me illustrate with a case. It's an anecdote, but it illustrates how good hydroxyurea is. 7-year-old male was in the clinic and had been in Canada for 4 years before he came to the clinic because he hadn't had any crisis. So he had a crisis in Toronto and was referred to the clinic. In 2004, he had 4 vaso-occlusive crises and was admitted. The same number the following year, 2 admissions in 2006, and 4 admissions in 2007. Now, throughout this period, there have been discussion about hydroxyurea, but the family had it had anti-cancer properties, and they were very squeamish about having this boy on hydroxyurea. But I mean, in 2008, he had 2 admissions, and he had missed 30 days of school between January and April. And so at this point, the mother was exasperated and said, okay, let's do hydroxyurea. So we started hydroxyurea therapy in April of 2008. Now, the benefits of hydroxyurea. So what you're seeing here is the beginning of hydroxyurea, and what you're seeing is the fetal hemoglobin rise, which is the hemoglobin that actually reduces the sickling. And as you can see, the response is very dramatic. Not all patients have this dramatic response. I see this a lot more in children and adults. The bone marrow of children is much more responsive. And you can see that this was blood transfusion. This is hemoglobin. The hemoglobin was steadily rising because you're not breaking down as many cells as you do when you have hydroxyurea. The neutrophil count reduces, and this is actually the right thing. All sickle cell patients who are not on any treatment have very high white cell count, and that's the evidence of the inflammation that is going on. And actually reducing that inflammation, that white cell count, is a good thing, provided you don't overdo it, and that's why you need monitoring. So you can see the neutrophil count come from very high on hydroxyurea and within the lower range here. And this is, this is the neutrophil count. This is the absolute reticulocyte count, which we had yesterday, and Dr. Bonavino showed how reticulocyte count are actually reticulocytes, Sickle reticulocyte, are very adherent to the endothelium. So reducing that is great, and it works very well. So you can see over time, there's a very good response with hydroxyurea. And this is a good way to monitor response, and your doctors show you all the time. This is a child, you can tell that the mother was so exasperated, she made sure this child took hydroxyurea. And the red cells are bigger as soon as you start taking it, and they continue to get bigger. And this is measuring how fast the red cells are breaking down. And I have found in my experience, the teenage girls love hydroxyurea because they don't look as jaundiced. And in fact, in many instances, the jaundice goes away. The yellowness of the eyes that everybody comments about, they find that it's gone down. And this is the bilirubin, and you can see how remarkably that has dropped in this patient. So he had a good clinical response, no hospitalizations, no vaso-occlusive crisis. Everything was going very well. Now, so hydroxyurea is now being studied in Africa. And in fact, if you're going to be at ASH, one of the major plenaries in ASH is going to be on hydroxyurea treatment in Africa. And I tell my Toronto patients, you're sitting before me, you don't want hydroxyurea. In Angola, in Kenya, in Ghana, in Uganda, children are now taking hydroxyurea and are benefiting from it. You have access, for them, ability to pay. In Jamaica, they use it to prevent stroke. They use it for patients who have severe crisis. The Jamaican government has put it on their national formulary to make sure people have access, but they still have inability to pay. So this is happening in Nigeria, it's happening in Ghana, it's happening in Angola, Kenya, and Uganda. So a lot is being studied on hydroxyurea. And in these settings, the only thing they are studying is how safe and how effective will it be in the African context. There's a standard of care providing evidence-based management of sickle cell disease. So when your doctor talks to you about hydroxyurea, it's based on evidence. It's not something they're trying to force on you. In fact, with the strength of evidence we have, if your doctor doesn't talk to you about hydroxyurea, it's malpractice. No less than breast cancer treatment. That a newer, more effective breast cancer treatment is now available, and you go to your oncologist and he treats you on the old protocol, which has a poorer outcome. You'll probably be saying that oncologist is malpracticing. We should not allow that to happen in sickle cell. No person should encounter the healthcare system with sickle cell and not be told about hydroxyurea. We see it far too often that they don't get that conversation. And when that conversation is had, it's held in so flippant a way, your child should be on hydroxyurea. Why not? And that's it. And what is hydroxyurea? It's an anti-cancer drug. Tell me, if you're a mother with a child, and you have such an interaction with a healthcare provider who says your child should be on hydroxyurea, and all they tell you is that it's an anti-cancer drug, you're obviously going to say no. Because the way it's been presented is totally wrong. And I'm going to highlight that a bit later. So there's a lot of effort now trying to promote hydroxyurea uptake, because I worry that if we don't use hydroxyurea well, we are not serving our patients well. So here, the American Society of Hematology has produced this. If you have time, I want you to access it, particularly for adults. It's been produced for adults because adults in particular are having challenges accepting hydroxyurea. And this has been prepared in partnership with patients. So the patients actually promoted this. and their physicians and health literacy experts. Because it turns out that we doctors are not often very good in providing information. We speak in a language that often doesn't really resonate with patients. And so they brought in literacy experts who really provide the information in a way that can be more understood. And this document is being produced, and I think it's a great asset to us. So let's go back to our case. So he had no hospitalizations from 2008 and 2012. Then in 2012, he had 2 admissions with vaso-occlusive disease. So he had gone without any admissions at all. So the question was, why? Why did this happen? It wasn't very difficult to tell why this happened. So this is a fetal hemoglobin. You can see that fetal hemoglobin began to drop. You saw the upswing that I showed you earlier. And as you can see, the MCV is beginning to drop. So he wasn't taking the medicine as well as he should. And this is a challenge. A medicine can be efficacious. That is, if you take it in the perfect world, and you're taking it every day, you can prove that it works. But it may not be effective because adherence is not as good. And as we advocate for sickle cell disease, we should advocate for better access to these medicines and better ways for people to be able to adhere to this medicine. So it became clear that a conversation needed to be had, and that was the reason this boy was beginning to have crisis. So these are the big questions. If hydroxyurea is clinically efficacious and minimally harmful and easily administered once a day and relatively affordable, I'm saying relatively because when you go to Africa and Caribbean, families are struggling to buy hydroxyurea for their families. Then in Canada, why then do a significant number of patients refuse it? And why do some patients fail to adhere to the therapy? What should we be doing to promote treatment uptake and adherence to this therapy? And I think these are questions that all of us have to answer together. Both the patients, their parents, their families, advocates, healthcare providers, and system policy makers. One mother told me, if hydroxyurea was that very effective, why is it that this is the first time I'm hearing about it? And it's a legitimate question because they see it announced on the radio for other disorders, for chronic asthma, for diabetes, and they're wondering why. So the system also has a part to play. So adherence, caregivers. We, the caregivers, have to show the patients the favorable blood results that they can get from this. And the way I do it in my practice is that I make every patient see their blood results. And I say to my patients, you should know what your baseline hemoglobin is. And they will do it if you encourage them. So you show them the favorable results, and they can tell the changes happening in their blood. Show them the loss of response when they are not adherent. So the 10-year-old sitting before the computer, looking at the MCV drop, the fetal hemoglobin drop, looks at the face of the mom, and mom says, I told you, you don't take your medicine. And that alone is some encouragement that there's a way of monitoring adherence, and one can emphasize that as well. Present data on impact of hydroxyurea on survival, because as we have been told by the patient community, blood counts is meaningless. If you tell me my white cell count is low, or my platelet count is low, or my bilirubin is high, it doesn't mean anything. What I want to really know is, does it really impact my health? And I think the evidence we are seeing that hydroxyurea is better at preserving organs than taking nothing is something that we need to emphasize, and that is improving survival. Social support is crucial. And if there's one thing that has emerged from this conference, I think we've heard it loud and clear that our patients and families need a system that supports them, almost like it does for cancer patients. If we can achieve that level of social support, that would be great. And then drug plans to ensure access. I mean, there's nothing that bothers me so much than to have somebody struggling to get access to hydroxyurea. I don't think that should happen. I think every patient who needs hydroxyurea must have access to the drug. What about patients and parents? Keep records of events and hematological parameters. I think when you record what you have, you are better able to monitor whether you're doing well. I have one principle in my clinic. I shouldn't know a result on a patient that the patient doesn't know. It's their information. It's not mine. And I shouldn't have a custody of that information without letting them know. And I think by keeping records of that, it helps both the patient and the parents to be able to help to monitor. And they should be involved in the child's hydroxyurea therapy as much as possible. Encourage electronic alarm systems as reminders, and the younger generation are more digital. They have smartphones that can help them remember to take the drug. And non-adherence could be signs of social emotional upheavals. And we see this very commonly. Somebody who was very adherent and then suddenly they lose their adherence. It's a signal that something must have happened. It may be loss of a loved one. It may be a broken relationship. It may be loss of job. It may be something that's significant that has given them, put them into a state of depression. And we've heard about mental health. I think mental health care for sickle cell patients is so under-delivered that we should do more to realize that anybody who lives with a lifelong disease as severe as sickle cell, it's almost like SLE, lifelong, not acquired. Any person living with such a severe disease will have challenges with mental health. We have moments when they feel they want to give up. We'll have moments when they are fed up with the medication. They just say, I want to give myself a drug holiday. I just want to go without drugs for 2 weeks, for a month. And that's the state in which they are. And what they need is not preaching to, is somebody who comes alongside to help them and to support them and to help them really come out of that state and go back to their treatment. So non-adherence for me, for somebody who was previously adherent, is always a signal that there may be some upheavals in their lives that needs attention. How do we combat ignorance about hydroxyurea therapy? We need to educate. And the thing is, I say to my doctors and sick kids that if you see any child who has sickle cell anemia, who is not on hydroxyurea, ask yourself, why not? And begin a conversation. Guidelines have been produced, but the production of guidelines do not translate into practice. And that's why patients have to have cards that tells exactly what they need so that physicians can follow. Canadian guidelines have been developed and we should utilize them. For patients and families, we need to educate them in a culturally appropriate medium and language. And that's where advocacy groups like the association can help in educating, because it's more likely to be culturally appropriate. But those who do the educating should be trained. So education requires skills. Not just everybody should be trained. We had an unfortunate incident in which one parent in our sickle cell program took upon herself to be an educator in sickle cell. It turned out that a lot of the information she was providing was inaccurate. And so education is so critical. There are people who are skilled at it. There are people who go and get PhDs in education, because education is very important. We should seek their help to really provide us a way to be able to do the education. The fears about hydroxyurea, I think, is a major barrier. The fear that it could cause cancer, the fear that it could cause infertility is a major barrier to patients and families. And I think we should be able to address that. And what we should do as care providers is not to wait for them to find out on the internet or to ask us the question. So when I present hydroxyurea, I'm upfront. I talk about the whole thing, about the fears that are out there to help patients deal with it. So neurological complications of sickle cell disease, I just want to spend a few moments to talking about it. This to me is the most devastating complication of sickle cell disease. Overt stroke, and is the severest cause of what we call moya, where you have blood vessels growing in the brain because the main ones have been blocked. And silent infarcts, the incidence of silent infarcts is about 37% by the 14th year of age if you have SS or S-beta thalassemia. And so this is a big problem, and I think that is why every sickle cell patient should have a medical home and should be seen regularly to look at this. The stroke incidence before stroke prevention strategy was implemented has been significantly high. What is interesting is that as the children age, the stroke becomes more bleeding rather than blockage of blood flow to the brain. And then it's restored to blockage of blood flow as they age. But with introduction of blood transfusions and transcranial Doppler, one has been able to reduce the incidence of stroke. This is the original study that showed a reduction of stroke if you use TCD. So we should not accept in Canada to have a child living anywhere in Canada with SS or S-beta 0 thal who is not having access to transcranial Doppler. If their province cannot do it, they should give this child access to a center that can do it. And Canada is so vast that we have patients who live in areas of Canada where they don't have access to transcranial Doppler. I think every child with sickle cell anemia should have access to cranial Doppler, because if that child suffers a stroke, the cost to the parents, to the family, to the child, to the healthcare system, to society is 1,000 times more than flying them to Edmonton to get a transcranial Doppler. And so in our advocacy, I think we should advocate strongly, because this is a major complication. Now, you don't have to stop your blood transfusion, because if you stop, those who continue blood transfusion in this study maintain health in terms of stroke or high TCD. If they stop transfusion, this is what happens, suggesting that they need to continue transfusion. This is data from the state of California, and that arrow is showing when they also started using transcranial Doppler to screen for stroke. And you see how precipitously this has dropped over the years. By 2000, the incidence of stroke has dropped. This is a success story which should be translated to every family. So, what do you do when you've had a stroke? When you've had a stroke, having no treatment for sickle cell is not an option. Because if you don't have no therapy at all when you've had a stroke, you have about 30 patient, 100 patient years that the stroke is going to recur. That means that if you take 100 patients, within 1 year, 30 of them will have a second stroke if they've had a stroke. Regular blood transfusions will reduce that to only 2 out of the 100. And hydroxyurea will reduce that to about 4. The message I want to give here is that if you cannot receive blood transfusion because of where you live, or because your hospital doesn't have the facilities, or because you've developed antibodies and you can't get blood transfusions, we heard that yesterday, then hydroxyurea is better than nothing, because that reduces it to 4 compared to 30 per 100 patient years. And I get so frustrated. I see some adults who've had a stroke with sickle cell, who are neither on blood transfusion or on hydroxyurea. They're looking for something that will cure the sickle cell. I think that should not be allowed to happen. Hydroxyurea is better than nothing, but better still, regular blood transfusions will prevent a secondary stroke. And this is the kicker. Silent strokes in sickle cell anemia doesn't stop in childhood. So this is telling us the incidence of silent stroke. This is work done in Vanderbilt University, where they look at their whole cohort of patients from pediatric to adult. And it seems that when you enter adulthood, you continue to have silent strokes. So adults with sickle cell disease, when you're thinking that you're losing your executive function, you are forgetting more often. Things that you should remember, you're not remembering. It's not simply old age. It may be that you're developing more cerebral infarcts, and your doctor should be involved in assessing you. And that is why organ damage is what should be our goal. And I'm showing this to illustrate that we have more work to do to prevent organ damage and to provide cure if we can get cure, because cure is the only way we can stop that. But in that process, we should also be reducing the rate of organ damage. So, in summary, evidence-based therapy is here to stay. But the fact that we have evidence does not necessarily translate into practice. More and more evidence will emerge, and many more will come, but we need to make sure that we apply them. Their proven efficacy needs to be translated into effectiveness, not for one patient, but for all patients. Patient families, providers, and system barriers need to be overcome, and we can only do this together. We need better outcomes for our patients, and to do this, we have to work together, because our ultimate goal is not just that they survive, but that their quality of survival is good. Thank you very much. Yes.
Thank you for your excellent presentation. I'm an adult provider, and Aisha and I talk all the time about the end organ damage that happens once her patients become my patients, and I try not to think that's a reflection of me, but as of the disease. But I think it just speaks to the fact that we need more research for care of the adult patients. We had a patient who passed away from an intracerebral hemorrhage 2 years ago, and on the imaging, he had severe vasculopathy in his brain, and there wasn't a lot of evidence of that before, even with regular MRIs. So we're doing MRAs on a lot of our patients now to assess for vasculopathy. And I think going forward, because this is such a vasculopathic disease, we need the research for how do we, what other things do they need earlier intervention for the classical cardiovascular risk factors in terms of blood pressure. It's harder to screen for diabetes because of their chronic hemolysis. All of these other things that, before patients were dying so much younger. So I always tell them I want patients coming to the clinic long after I've retired, which is hopefully for a really long time. And so we need to figure out how we can care for these patients as they're aging. So and thank you for emphasizing, we're trying to prevent end organ damage. Like, to me, that's so important. So.
Absolutely, thank you for what you said. And actually, we pediatric hematologists have the best opportunity to set these patients on a different trajectory. We have them for just 18 years, and we push them to you for the rest of their lives when organ damage sets in. So you're right that you are receiving patients who already are on the path to organ damage. Is it possible that we pediatricians can modulate that trajectory so that when you receive them in better health? And I think we pediatric hematologists shouldn't delude ourselves, because people say, oh, pediatric care is good, it's fine. It's because the patients haven't as yet had end organ damage. It all comes to light when they start having the kidney damage, the heart, and everything much older. In fact, Dr. Gary Gibbons, who is now the director of the NHLBI, National Heart Lung Institute, when he became director, said he was a cardiovascular researcher, a very renowned cardiovascular researcher. But when he became director and he started interacting with the sickle cell blood disorders wing about sickle cell, he realized how similar sickle cell is to cardiovascular disease, except that it is happening from birth. So he said his eyes opened and he realized that these risk factors, your blood vessels are being damaged all the time, except that this happens right from infancy. And that's why more research is going to sickle cell, because he realized how we needed to study this disease and do more research in adults to be able to understand the vasculopathy. I think brain MRI, MRAs should be more commonly done. I think many patients are going through our clinics without brain MRI and MRA, and I think we have been able to, there are even surgical techniques to help some of them who have severe stenosis, where you can do bypass surgery to protect the brain. So we should look at it as preventing organ damage, and that changes the paradigm. So then the notion that my patient is not having crisis is not good enough. We need to make sure that they're not getting organ damage. Yes?
So, just about to revert back to, there's a couple of things I wanted to say. First thing is that the the prevention of the end organ damage is really a focus of our clinic.
Right.
What we developed was we actually give every patient a list of what the recommended screening is that you should have every year, every 2 years,
Right.
and we want you to advocate for that.
Right.
This is your health. If you notice, oh, guess what, I haven't had that in a couple of years,
Yeah.
why haven't I had it?
Yeah.
Like, you need to be pushing and asking us for the health care that we're here to provide. Just in terms of the hydroxyurea, huge amount of pushback on hydroxyurea.
Yes. Yes.
Huge.
Yes.
People do not want to go on. I feel like I'm the wicked witch of the West, pushing hydroxyurea. I feel like I'm a drug pusher. And people resent me. I know that they resent me because I try to promote it so much. And it's not that I'm trying to promote it for my benefit. It's just that I know all the benefits that it can do. Having said that, from the time I started working with sickle cell patients, over 3 years ago, I am more than doubling the amount of patients that I monitor hydroxyurea.
Congratulations.
That in and of itself is a huge amount of extra work for me because I'm having to check all their blood results and nag them and email them and please do your blood work. I've done your blood work in 2 months and whatever. Or are you taking a pill? I noticed I had checked the pharmacy records. You haven't picked up your Medicaid. You got 30 days worth 60 days ago. That means you're not taking it. Oh yes, I'm taking it. No, you're not. You're not. And so I feel like I nag, but honestly, I don't have enough hours in the day to do justice to this therapy. I mean, once they get to their MTD, that's great. If we can get them to be adherent enough and committed enough to the therapy to actually start it. And I did start trying to bring people in for education sessions before they started it, but it's really kind of prohibitive. I mean, I feel like they've just had so much information lambasted at them all the time, and that it's there's only so much. And fear only works so much, right? Like it's about feeling empowered that they have some control. That fatalistic part can be taken away because sometimes it's just fatalism. They feel like, well, the damage is done. You know, it's hard to take this. My hair is going to fall out. My nails are going to go dark. And it's like it's very hard. I understand it. I get it. But I mean, I feel like it's a slog, and it's like throwing mud at a wall. And hopefully, eventually, it'll stick. It's what you said is really valid.
Very well said. But to assure you, frustrating as it is, I think you're doing your patients a lot of good. The fact that you've doubled the uptake, I think is significant. Adherence to medication is not only a challenge in sickle cell, it's a challenge across the healthcare area because people find difficulty taking medications. But I think one thing that we can do is that in the adult world, it's good to get the spouses involved so that one spouse might be a good encourager. And I'm saying this because if the spouse doesn't see the other spouse who needs to take the medication taking it, they can be a monitor for them. So it's not only for healthcare providers, it's also for family members to get engaged. But regarding the uptake, I have to tell you, I've learned a lot when I get to the ward and I'm told that this family has been educated about hydroxyurea over and over, and they still say no. And I go in for 30 minutes and I'm signing a prescription. And people say, Dr. Dame, how did you do it? We've been trying to do this for 5 years. And the thing is, no matter where they come from, whether they are new immigrants, whether they are highly educated, whether they're not highly educated, they all understand what a double-blind placebo trial is. And don't underestimate this. It worked once for me and I've used it every time. Because this dad was a physician whose child had S-beta thalassemia, and he wouldn't want the child to be on hydroxyurea. But nobody had explained to him how the evidence for hydroxyurea efficacy was generated. So when I went in, I knew he was a physician. So I went in and I said, oh, I'm new here. I had then gone to Toronto. I'm new here, and your child has been doing well so far, but you've had some challenges. I want to talk to you about hydroxyurea. He said, oh, yes, I don't want it. And I said, if you may, since you're a doctor, can I explain to you when the evidence was generated? So that trial, the placebo trial, double blind, nobody knew who was taking real, showed him the evidence. You know what he asked? He said, why didn't anyone explain to me? So since then, I've found a way to explain a double-blind placebo trial even to the not too well educated. They love the idea that there's no bias. They love the idea that the medical staff, the nurses, the doctors, the patients had no idea who was taking placebo and who was taking real. And they love the idea that when the evidence was generated, it was a committee that had no insight into who was taking what. And then you tell them this was replicated in children. And then I tell them if this was asthma, and if this was breast cancer, maybe everywhere you go to see your doctor, they will say, ask your doctor about this. But the reason why you don't is that sickle cell patients are so small, and also it affects the minority. And then they look me into the eye and they say, doctor, we get it. We get it. We now get it. Why nobody else have told us about hydroxyurea. But that requires time. And I think our clinics are so designed in such a way that not enough time is spent. And I can see the agony on your face, the time you're spending to get your patients to adhere. But we shouldn't give up, because I worry that voxelotor will come, other molecules will come that have to be taken once a day. It may be in combination with hydroxyurea, and because adherence to them is not as good, that we're not going to get good outcomes for our patients.
So I found that in the sickle cell community, hydroxyurea sits in this very strange place where it is either, when you talk to patients and caregivers, the best thing that's ever happened, it's just the most amazing miracle in their life, or it is the absolute devil. I'll never touch you, get away from me, what's wrong with you? There doesn't seem to be a happy in between. We approach everything else with a happy in between. This has worked, this hasn't, what do you think, do you like it, do you not? Except hydroxyurea. Hydroxyurea has often been presented by our physicians as though it's a cochlear implant of the sickle cell community, some kind of cure-all. And then when you hear people that say, well, it didn't work for me, there's just this dichotomy, there's this separation in the minds of our community where there isn't a logical discussion that's happening. And so patients either feel like this is the best thing, or they feel like it's being shoved down my throat and I don't want it.
Right.
And I think we're going to have to figure out a way to find that in between.
Right.
Because in all the evidence that you showed, we know that it will help some. We also know that there are some that won't respond.
Yeah.
But explaining that to the patient, explaining that we recognize this is not the messiah of sickle cell. However, here's the evidence. I think that bit is missing. I think that it's either presented, like I said, as do this, it's going to stop all the inworking, you've got damage, you've got to do it, you've got to do it. And that's clearly not working. We've got to find that in between. And I really think a lot of that's going to have to come with education. And on both sides, there's a way in which this drug needs to be presented, and in a lot of ways, it hasn't been.
You're absolutely right. And one thing that I do, I realize that, particularly in my pediatric experience, parents find it a daunting task to take a decision for their child which has lifelong implications. So when you present hydroxyurea, the first question, how long? And you say, for as long as the child has sickle cell. And then the burden on the parent of taking this decision for the child becomes daunting. So what I do is that I invite the patients to go on a journey with me. Let's start a journey. If it doesn't work, you can stop anytime. If it doesn't work for you, just like any medication, or if you have unwanted side effects, you can stop. But let's start and see what results we get. And let's not commit ourselves to lifelong treatment yet. We don't know whether it's going to work, but we can make that decision from time to time. And as you said, that gives them a little bit of assurance that this is not a done deal, this is not a lifelong treatment, this is going to be evaluated. And there are, in the adult world, there are true non-responders that do not respond well to hydroxyurea. And so when you are presenting it, it's a journey. In pediatrics, what happens is that they are so thankful after 6 months when we do the evaluation, and a year. And the question is, will you like to continue? And they say, you're kidding me. My child was being admitted 4 times a year. This whole year it's been improved. I want to continue. So you're right. It has to be, the conversation has to be real, and it has to be on both sides, trying to present the evidence as it is.
I know one of the things that has helped me, and I don't know if every patient is open to receiving their results online yet.
Yes.
But getting those apps and having that ability to check my blood work and monitor my blood work is, because that's the evidence right there.
Yeah.
And it really hits home. And I even like seeing it when I see my apheresis treatment, right? And I see what my blood work is before my treatment, after my treatment. It's an excellent way to confirm that the treatment that I'm on is working.
No, absolutely. And the patient, we forget it's about the patient and empowering them to monitor their own care. It's been shown.
And your point about, the physicians and the nurses shouldn't be the gatekeepers to that information.
No.
It belongs to the patient.
It belongs to the patient, absolutely. And I think in Canada, whether we like it or not, every province, we are going to get to a point, in fact, we started in our hospital, where patients have access to all the records in terms of laboratory work. And the idea is that it is for the patient, it's their information, and they should be able to look at it and use it to manage their case better.
The reality is, Apple probably has it, and they're using it against you.
Exactly.
So as the consumer, you should be able to see that.
Absolutely.
Yeah.
Yes.
In Alberta, at least in Edmonton, we do sign our patients up now for My Chart, which is the patient portal where they can see their own lab work.
Right.
And as we're moving to a provincial EMR, that will be available for all patients probably within the next 1 to 2 years. So that's been newly available in the last year for Edmonton patients, and that is, so the patient portal is here and coming. Adults, we don't have access to it yet in pediatrics.
No.
Non-pediatric?
No,
Not yet.
and in fact, our clinic was the second pilot clinic. So I think it was rheumatology and rare blood disorders. Still very central bleeding. Yeah, so they're gradually introducing other ones. So it's great because I do get phone calls from patients saying, I saw my this result or that result. You know what's going on there? And I'm like, bring it up on the chat. And I love that.
Yeah.
It's not like they're catching me out saying, you're not looking at my blood
No.
results every day.
No.
They know I can't look at their blood results.
Exactly.
Like, they can't. There's only so much. There's only one person. There's only much we can do. We're a team, and as I always say to them, if you're concerned about anything on your chart, you contact me. Let's look at it together or whatever. It's
But then you have to give your patients the chart, right?
Oh no, I do.
Everybody,
Exactly. They have to have that power to be involved.
If you want patients to be empowered for their own care, they need to be able to see those steps.
Because I'm a patient too, and I have access to my chart too, and I love it.
Yeah.
Not a sickle.
Well, I think I'm happy with the progress we're making in that the patient voice is now being strongly promoted, not only in defining research, but also in defining the care. And I think the more we do that, I think we'll be coming closer to meeting the needs of patients and really getting better outcomes. So it's about patient empowerment. And I think we healthcare providers need to change the paradigm of treating sickle cell as a crisis treatment, and we call the shots as to how it ought to be treated, to a lifestyle end organ damage prevention that empowers patients and makes them the center of the care. That is the model of care that we need to give them the best outcomes. Thank you very much. Jane will have the last word.
Selfish. Do you have any research on sickle cell trait in terms of end organ damage?
Oh, I can tell you, sickle cell trait is creating a buzz, and more is being researched in identifying consequences of sickle cell trait, particularly with age. Whether or not the research is adequate is really an argument that some of us are making, because what we don't want to happen, that the pie is divided in such a way that resources that should go to sickle cell research and advancement is shifted. Although sickle trait is important and it needs to be studied, I am anxious that in doing so, we don't shift the pendulum and lower the acceleration on sickle cell research. But it's an area of great research, and we are learning more and more that sickle cell trait may have some consequences in the adult age.
Yeah, because I'd like to remind us who have sickle cell trait to look at the literature that's coming out and follow it, because I found some startling results because I have diabetes.
Right.
And I found it was, I couldn't take one of the medication before.
Yes. Yeah.
You know?
Yeah. No, it is relevant, and it should not be ignored at all. And there's more interest. In fact, the NIH is focusing on it as a separate. Another area that is being studied, and I was hoping somebody will ask, if you have SC disease, there isn't a lot being done in SC disease, but that's about to change, because almost all the research is done in SS and S beta zero thalassemia. But SC disease is a milder disease, and I think if I could describe SC disease, is shifting the whole sickle cell end organ damage a little further on. It doesn't mean they don't get organ damage. We see them getting organ damage when they are much older, but they need care, and they need to be cared for to make sure that they don't develop early organ damage. It needs real study, and the NIH is now beginning to balance that. People with SC disease have always expressed their frustration that they tell us, oh, the evidence is for SS, how about SC? We don't know. But a significant proportion of our patients, certainly in Canada, 35% of our patients in Toronto are of SC disease. It's a little lower in the United States, but it's a significant number that needs to be studied. Thank you very much.